Good morning, good afternoon, and good evening. Distinguished guests, esteemed colleagues, honored speakers, and dear attendees. I am Dr. Cherian Verghese, Professor and Director of the Prasanna School of Public Health at Manipal, Mahi, India. So it's my privilege to welcome you all to the closing session of the second edition of the Professor Rajani Prasanna Endowment Lecture Series titled Climate Change and Impact on Public Health. The first edition, as some of you may know, was from 2021 to 2023 and resulted in the publication of a book covering 11 lectures. The second edition, which began in September 2024, has grown into a vibrant intellectual platform over a relatively short span of time. With 7 lectures completed so far and culminating today on 2nd of May 2026, the series has already brought together 16 distinguished speakers and engaged an audience of over 700 participants. These numbers reflect not only scale, but also the depth of curiosity, collaboration, and commitment that this initiative has inspired. We have had the honor of hosting speakers from globally respected institutions, from the UN University in Belgium, City University of New York, WHO Collaborating Center for Investment for Health and Well-being at the University of Taiwan, Cambridge University, Emory, and several other leading organizations. This endowment series is not just merely a series of talks, it's a sustained effort to bring together knowledge, dialogue, and action. It reflects a belief that meaningful change emerges when ideas are shared across domains and when scholarship engages with real-world concerns. As we come to the conclusion of the second series of the climate change and impact on public health, we look forward to continuing this journey of collaboration, learning, and societal impact. We hope that the conversations initiated here will inspire new collaborations, deepen understanding, and contribute to building more resilient and sustainable futures. Thank you all for being part of this important endeavor. So let me start today's function by welcoming Madam Rajani Prasanna. She is the person behind making this endowment series happen. I also take pleasure in welcoming Mr. D.A. Prasanna, the chair of the Prasanna School of Public Health Endowment, Ms. Surabhi Gurukar, who is also part of the team, who have traveled all the way from Bangalore to be here with us, which gives us great enthusiasm in making this happen. So let me now invite Madam Rajani Prasanna. Let me also say a few words before Madam speaks. Professor Rajani Prasanna is an Indian art historian, academic, and philanthropist known for her contributions to the study and promotion of art, culture, and interdisciplinary scholarship. She is recognized as part of the artistic lineage of the eminent modernist painter K.K. Hebbar, whose legacy she continues to support through cultural and educational initiatives. An accomplished scholar, Professor Prasanna has been associated with art historical teaching and has contributed to the dissemination of knowledge on classical and modern art traditions. Beyond academia, she is actively engaged in philanthropy and institutional initiatives that promote dialogues across art, culture, public health, and sustainability. She has played a key role in supporting these lecture platforms focused on climate change and bringing global experts from leading institutions. Let us hear a few words from Madam Rajani Prasanna. Over to you, ma'am.
Thank you. Good evening, everyone. I would like first and foremost to thank Dr. Professor Cherian Verghese, who is with us and who is the main. And also I would like to thank Dr. Professor Henry Falk and our moderator, Vikas Kapil, who has been a main part and who has helped a lot, been a part of the whole system. Now, climate change is, as Verghese just mentioned, was started in 2021. And it is the time when we had COVID, if you remember. And that was a strong impact on the environment. And people who never thought that there could be something like COVID began to realize the impact of the disease all over. Similarly, I don't think anyone took seriously about climate change at the early stage. When we began the talk, a series of talk in 2021, it was mainly research papers which were read, beginning with Henry Falk, Dr. Henry Falk, and a couple of many others over a period of time. And this set a trend, but I don't think it has reached across to the public the seriousness of climate change and its impact on their own health and on their own profession. It is a second series. I suddenly realized, attending those talks, that now it is the period time when they have started taking action, and there is a collaboration between the people, the public who are responsible, and also the different people who are in charge of promoting or helping out troubled places. Let me give you an example of Dr. Balvasar, who spoke last week or week before, and he said how he took into collaborated with the local people while rebuilding their houses after the tsunami. So it is not just the climate change which is causing, but now it has gone beyond control. We are experiencing climate change so drastically that we see it all around us. And we also feel very much in the city where I live, it is in Bangalore, which had such a pleasant temperature and very cool. And people came to reside or retire to Bangalore only for its weather. But today we are experiencing climate going as high as 38 to 40 degrees. So this is causing a lot of damage. We have rains when we don't expect. So the climate change is affecting everyone, immaterial what profession they are, what they are doing. It is even the common man has begun to realize that the climate effect has changed him. Let me quote something which was written by K.K. Hebbar years back. It is 30 years since he's passed, but this must have been quoted by him in one of the articles about 50 years ago. He said, "My works are generated by my intense feeling for my environment. I seek to find myself by following whatever course it takes." So even at that time, even artists were seeing or showing the relationship of an artist with the environment, his observation of the reaction. And that time it was not anything as drastic as today. Today we talk of wars, we talk of missiles, and what has happened to the air around us. The repercussion will come within a short time. And we are all going to fall ill in different ways, which will be a new stage, a new research which will have to go to find solutions for the newer disease. And each time, each decade, we see newer and newer. So I'm hoping and I'm wishing PSPH, which has done such wonderful work all these years, will continue to do this and help us to also to be a part of it and bring about this change, which is very much wanted. Thank you.
Thank you, ma'am. And thank you for making sure that the lecture series has been going on very well. Thank you very much for your kind words as well. As madam said, human beings are the only species that is destroying its habitat and then crying about it. I don't think any other species on this planet, and maybe other planets also may not be doing this. Okay, we have another guest of honor today, and it is my proud privilege and pleasant honor to invite Professor Dr. Henry Falk. Dr. Henry Falk is currently Adjunct Professor of Environmental Health at the Rollins School of Public Health, Emory University, Atlanta, Georgia. He is also a guest researcher at the CDC. Dr. Falk is the former director at the National Center for Environmental Health at CDC and also the former director of the Agency for Toxic Substances and Disease Registry at CDC. He also held other senior leadership positions at CDC. Concurrent with his work at CDC, Dr. Falk was Senior Commissioned Officer of the U.S. Public Health Service, attaining the rank of Rear Admiral and Assistant Surgeon General of the U.S. Public Health Service. Dr. Falk earned his medical degree from the Albert Einstein College of Medicine in New York, trained in pediatrics at Children's Hospital of Philadelphia, and is board certified. He also holds a master's degree in public health from Harvard School of Public Health. He is also on the advisory board of the Prasanna School of Public Health, and I would consider him as a friend, philosopher, and guide. So, Henry, over to you for your remarks.
Thank you so much for those welcoming remarks. And it's a special privilege for me to be able to participate in this program with Mr. D.A. Prasanna, Professor Rajani Prasanna, yourself, and Dr. Varghese, and our distinguished speakers and guests here tonight. So I've had a special opportunity to be involved with this program from the very beginning. I actually spoke at the opening program for the first lecture series, and now I have an opportunity to speak at this closing session for the second series. So I've seen this develop from an idea or a vision at the beginning into actually a very dynamic forum for bringing together distinguished scientists from across the globe, and it crosses disciplines, it crosses geographic boundaries, and leads to very stimulating and meaningful dialogue among experts. So we've had some really very excellent lectures over these several years. And just several that come to mind. Professor Mala Rao spoke about profound implications of climate change on the unborn child. Dr. Tom Matei, who spoke about urban air pollution and climate change and the challenges faced in New York City. Drs. Rima Habre and Dr. Jessica Wang, who spoke about vulnerable populations and understanding how climate change disproportionately affects certain groups. And today you're in for another treat. I know both of today's speakers well from my time at CDC and at Emory, and so we have two really very outstanding lectures today to round out this second series. So I think it's important to note that we are no longer talking about something in the future. Climate change is here. It is with us right now. It's altering patterns of disease. It's exacerbating exposure to environmental hazards, and it's intensifying health inequities. And vulnerable populations such as children, the elderly, low-income communities, those in climate-sensitive regions, those with chronic diseases, they all bear a disproportionate burden and, are extremely going to be impacted by this. As a pediatrician, which was how I started my career, I especially care about children. And, climate change will have its deepest impact, not on us who have lived a good portion of our lives already, but it will have the deepest impact on the children who are coming forward. And we already know about the impact of climate change on fetal effects and on the growth of children early in their life. So these are the reasons why this lecture series is a platform that has been so valuable. It creates a space for scientific exchange, for cross-sector collaboration, and for translating knowledge into action. It reminds us that this is not just an environmental imperative, but a public health one that we have to respond to. And as we move forward, we want to continue to build the work in this area, and this forum provides a good medium for exchange of ideas and for coming up with newer approaches. I think it's just a very valuable way of addressing this problem. So I want to take this opportunity to acknowledge and commend Professor Rajani Prasanna for her vision and continued support, which have made this initiative possible. Her commitment to fostering dialogue at the intersection of climate and health and society is timely, it's impactful, and you just heard her speak very forcefully about her commitment and interest. So I want to again express my thank you to Professor Rajani Prasanna for all that you have done to make this effort such a valuable one. And so thank all of you who are participating, and I look forward to today's lectures. Thank you again.
Thank you, Professor Falk, and thank you for your continued guidance, and we look forward to have that as we move on. The next part of the session actually starts with my introduction to the moderator, and I'm very pleased to introduce today's moderator, Dr. Vikas Kapil, who is actually currently the international faculty at PSPH. But prior to that, he served as the Chief Medical Officer and Associate Director for Science at the Global Health Center for the US CDC in Atlanta until September 2024. He was responsible for oversight of science, quality, scientific integrity, and ethics and extramural research programs for global public health activities for CDC, including over 60 country offices around the world. He first joined CDC in 2002 and served in many positions, and as acting Deputy Director of CDC's National Center for Environmental Health and Agency for Toxic Substances and Disease Registry. Prior to joining CDC, Dr. Kapil practiced emergency medicine and also served as the Director of the Department of Occupational Medicine at St. Luke's Hospital in Ohio and Associate Senior Vice President for Occupational Health and Safety at the University of Cincinnati Medical Center. So I think we have a well-rounded person to moderate the sessions today, and without much ado, let me pass over to Dr. Vikas Kapil for running the next segment. Thank you, and over to Vikas.
Thank you very much, Dr. Cherian. I don't really know where to start except to say that I have the distinct honor of introducing our two outstanding speakers today. They are, as Dr. Falk said, friends, colleagues, and we're thrilled that we're able to organize this last session in the second edition series, the Climate Change Lecture Series. So we will have two speakers today. The first speaker, Dr. Shubhayu Saha, is the Director of Tracking California at the Public Health Institute. He leads the implementation of community-engaged climate resilience programs and dissemination of environmental health data. Shubhayu brings 20 years of experience addressing climate change-related health risks, especially in communities which are disproportionately burdened by climate change. Prior to joining the Public Health, the Tracking California, he was with the U.S. Department of Health and Human Services and also with the Climate and Health Program at the U.S. Centers for Disease Control and Prevention. He has served as a co-author of the last 3 U.S. National Climate Assessments and is a founding member of the Global Heat Health Information Network. Dr. Saha received his master's in economics at Jawaharlal Nehru Technical University in Hyderabad and a PhD in economics and policy, as well as a certificate in geographic information systems from North Carolina State University in Raleigh, North Carolina. After Dr. Saha presents on translating science and data into action, we will have our second speaker, Dr. Noah Skowronek. Dr. Skowronek is a Rollins Distinguished Associate Professor of Environmental Health at Emory University. He serves as the Deputy Director of Emory's Climate and Health Actionable Research and Translation Center, which is also known as CHART. He's also the Director of Emory's MPH Certificate Program in Climate and Health. He earned his master's degree in biology from the University of Cape Town, as well as a master's and a PhD in environmental public health from the London School of Hygiene and Tropical Medicine. His research focuses on 2 core dimensions of the climate and health challenge. First, he's engaged in epidemiologic studies on the associations between health outcomes, both mortality and morbidity, as well and climate-sensitive health risks, including heat, air pollution, and so on. Secondly, he evaluates the impacts of greenhouse gases and gas mitigation strategies on population health and equity. He's published extensively in many leading journals, including Lancet, Circulation, as well as the New England Journal of Medicine. He will be speaking today on a very relevant topic for all of us on building university research capacity in climate and health. So without further ado, it's my pleasure to introduce first Dr. Shubhayu Saha, who will take us through translating science and data into action. And I would ask, please, if all of the attendees online, to please make sure that your microphones are muted and unless you're speaking. And then secondly, please hold your questions. If you would like to put questions in the chat, please feel free to do so. And hopefully we will have time after both Noah and Shubhayu have spoken. We will have time for at least a couple of Q&As after their presentations. So Dr. Saha, over to you for your presentation.
Thank you so much. What a pleasure it is, for me to, be part of, this, distinguished lecture series. It was so inspiring to hear Dr. Prasanna talk, so, passionately about, how we, really need to sort of transition from continuing to do the good research that we have been doing over all these years into this sphere of action where we, specifically target our, initiatives and programs and interventions for communities who are disproportionately impacted. You must have heard, that, climate change is, the climate crisis is actually a health crisis. And, I might sort of go that additional step and say it's actually a health equity crisis, that we face, across the globe. And, it's just remarkable to see, this level of institutional support that, that exists at PSPH, and it's very inspiring. And so, just, on that sort of note of, health equity, the title here is Protecting Everyone from Heat. Yes, we recognize that, no matter who we are, no matter where we are, global warming, extreme heat is, impacting us in ways, that we quite didn't expect, quite, and some of us are, quite unprepared, to deal, with this crisis that we face, every summer, the crisis that keeps worsening. But I would really like to emphasize that, our efforts, the science, the data that's generated, really needs to be leveraged so that we are, providing, support to the specific vulnerable communities and individuals who are, completely unprepared, to deal with this crisis. I just wanted to, maybe start with a little bit of a personal journey. I was born in Calcutta. I still say Calcutta. I don't say Kolkata. And spent my formative years there. Went to college, then came to New Delhi. It's actually Jawaharlal Nehru University. Where I got my master's in economics. Once I had that degree, I was always interested in environmental issues, and I spent a couple of years, working on joint forest management. This common property resource management, that exists now, across India, trying to understand how this human environment interaction and how local communities so effectively have managed this resource over many years. I then came to the US for my PhD, where I essentially worked on two different projects. One was looking at the impacts of iron ore mining in Orissa, the impact it had on environmental health and occupational health. And then I was also studying effects of deforestation in the Brazilian Amazon. And, once I graduated, this opportunity came up to join Centers for Disease Control. I really didn't have any training on public health, though I was interested broadly in human development and human environment interactions. And, so that was a leap of faith for me. I joined CDC as a prevention effectiveness fellow. It was, a fellowship program, where economists, mathematicians, operations researchers, decision analysis would come and do health policy research. I did that a couple of years, and then my gratitude to Dr. Falk and Dr. Kapil for really opening that space within CDC where the climate and health program started. And, that was way back in 2008, 2010. And, I joined that program, and, this has been my calling, since. And so, one of the reasons why I thought I would sort of, share this sort of meandering career trajectory that I've had and how I kind of landed, in this sort of climate and health space, because I think it would sort of, resemble a lot of choices that students would make or professionals would make who, start their career, whether, as social scientists, whether as environmental scientists, whether as climate scientists, whether as physical scientists, and then find that, this climate and health space offers, potential applications of the expertise and the science, that they produce. And, so, specifically for upcoming students, no matter what your expertise is, whether it's in social sciences or whether it's in public health or whether it's in, environmental sciences, there is, or communications as well, there is huge opportunities for you to engage in this field and contribute, in ways that would, enable us to, protect lives and livelihoods from the impacts of climate change. I thought, a little bit of context setting would be really useful as, I start this, my remarks. Human caused, climate change, anthropogenic climate change is essentially, causing a lot of these societal harms that we are, currently struggling to deal with. This particular graphic essentially shows, how carbon dioxide levels in our atmosphere has increased over the last, 150 years or so, and how that's, in the last 60 years or so, how it's led to, this remarkable increase in, global, temperature levels. as you see from 1960s onwards, there's been sort of a remarkable increase in the carbon dioxide levels, which has climbed. The rate of increase has been 5 times as fast as what we had observed in the period before 1960. In a historical context, this level of rise of carbon dioxide would have been expected over a range of 5,000 to 20,000 years. But because of deforestation, because of burning fossil fuels, we have managed to do it in 60 years. And at the same time, this rapid, increase in global warming, primarily, through the contributions of CO2 and other greenhouse gases, has been absolutely, startling. And this particular graphic is from the Intergovernmental Panel on Climate Change, the 6th Assessment Reports, which essentially assembles information from the latest generation of climate models, and how they project the planet will continue to warm based on different levels of emission scenarios. So the graph that you see at the bottom, the one in green, essentially shows that if we are successful, and that's a big if we are successful in significant emission cuts, that global temperature levels could be held, within a 2-degree, Celsius rise over the pre-industrial average. However, the modeling indicates that, with no emissions cuts and lack of, global, climate, mitigation efforts, this temperature rise would be far more significant than the 2 degrees, that we, predict, would lead to irreversible damages, across the globe. So the report really emphasizes the urgency in global climate mitigation to avoid the unmanageable future that we are hurtling towards. But at the same time, the report also draws attention to the importance of adaptation strategies that, if implemented now and if implemented in scale, can really help us manage the unavoidable consequences of global warming and effectively protect human and ecosystem health. So, in my remarks, I would be mostly focusing on the adaptation side of the challenge that we face, with a specific focus on protecting human health from the impacts of extreme heat. And so if you look at the, the current trend, the 10 hottest global years on record globally has been in the last 11 years. This statistic is quite remarkable. And as we are, dealing with, these consequences, in many situations, in many countries and many communities, we clearly see that we are quite unprepared to deal with this situation. And what does this global warming mean for us? Those of us who are in this sort of public health domain. It is a wicked problem that we face. And this particular graphic, it's a complicated graphic, but it really shows the complex challenge that we face as we try and figure out solutions that would mitigate these health risks associated with various dimensions of climate change. And so, because of these global phenomena, we are experiencing rising temperatures, we are experiencing more extreme weather, rising sea levels, which lead to multiple, environmental hazards related to air pollution, related to wildfire and smoke and drought and such, which have, far-reaching ramifications on every dimension of public health and health outcomes that you can think of. So if I want to, share a few examples, we generally sort of distinguish these impacts between direct impacts and indirect impacts. When we talk about direct impacts, we would, think about these acute exposures and acute health outcomes associated with it. So for example, when there are wildfire, the smoke from wildfires would have immediate consequences on those, suffering from cardiovascular or respiratory complications. If there is a severe weather event like a hurricane or a flood, there are a host range of injuries associated with those events, as well as loss of homes. Then there are these indirect impacts which happen over a longer period of time, and the pathway from the hazard to the health outcomes are a bit more complicated. A particular example would be, how climate change is impacting vector-borne disease, which is sort of mediated through these environmental ecosystem changes, which, increase the suitability of vector habitats in regions where, those vectors were not present before, and, thus leading to, a much larger, number of individuals who are impacted by, a range of different vector-borne disease. Food system impacts is again, another example where impacts, happen over a much larger, time scale. The other thing to really note here is, that outer, ring that you see around mental health impacts. There is this growing body of literature which essentially, focuses on, how all these different kinds of impacts have both short-term as well as long-term mental health consequences. A particular example of that long-term mental health consequence, comes from, displacements of populations, due to hurricanes or floods. The experience of the United States during Hurricane Katrina as an example, as well as, these hazards are stressing communities that are already suffering from existing, socioeconomic inequities related to poverty, related to housing conditions, related to, places where people live, with very, little resource, very limited, access to healthcare. And, climate change or these climate hazards in these situations are just an additional stressor for these communities who are already struggling, in terms of their well-being. And so, this is what we face. This is the complexity of the challenge. And, most of, what I would, continue to sort of draw examples from, would be this domain of extreme heat and, the direct variety of heat-related, a variety of health outcomes, ranging from heat-related illness and deaths, to cardiovascular and a range of other chronic conditions. So I don't need to share this reality with you. This reality is, happening with, absolutely tragic regularity. This is happening early in the summer, and you can, I follow news. I see how these early summer heat waves in March and in April, are becoming so intense and so severe, that it almost feels like we are in the middle of the summer. This graphic on the left is essentially what the Indian Met Department, the India Meteorological Department, issued on 27th of April. Where temperatures were ranging between 40 to 46 Celsius, with the highest being recorded in a place in Uttar Pradesh where the temperature was 47.6 degrees Celsius. It really begs the question. Do we know, what is happening? Do we know what the health, related health impacts for these are? Are the communities being warned appropriately? And what sort of solutions do these communities have, to deal with these extreme weather conditions? These are again, routine, we are almost sort of, this has become a new normal. We are sensitized, to this reality, where thousands of people are succumbing, to, heat exposure, most of it, happening in communities who have very little resources, to protect themselves, during these situations. But these numbers, again, beg the question, how credible are these? And how representative it is of, the true health burden that's associated with, heat-related outcomes. It's a slightly complicated slide, but I think it's important because it sort of breaks down how how does exposure to extreme heat lead to these adverse health outcomes, that I just mentioned, or that these newspapers were referring to. So this is this framework which helps us understand climate vulnerability, climate and health vulnerability. And so there's sort of three broad elements to this. One is this box exposure on the left, which is basically how frequently and how directly are you exposed to this hazard. And so this would be opportunities for us to track heat waves. It would be opportunities to understand how these exposures are higher in urban areas because of the urban heat island impact, where because of lack of green cover, the ambient temperature is much higher. Maybe people who are working outdoors are exposed to heat disproportionately more because of because they spend more time outside. People living in poor housing conditions are probably more exposed to heat because the heat gets trapped in their house, and their exposure is much more prolonged. then we come to this, element called sensitivity, which is basically, outlining what are these intrinsic factors, that make a particular individual more susceptible. And so we know older adults and children are more susceptible, as Dr. Falk mentioned, at the beginning in his remarks. There's a range of chronic conditions, pregnant women, individuals who are disabled are particularly vulnerable. And so are those who are socially isolated, or who, the ones who suffer from homelessness as well. And then this comes to the solution piece, where if we have adaptive capacity, we would have lower levels of vulnerability. Air conditioning is probably, the most effective measure of individual or collective cooling strategies. Many communities do not have adequate access to air conditioning, and then we sort of think about these other kinds of strategies where these built environment initiatives like tree canopy or shade structures, social systems like cooling centers, community support systems, better access to care, and various kinds of governmental policies related to income, insurance, and health insurance particularly are potential solutions which make individuals less vulnerable to these heat exposures. And this vulnerability, which is then this construct, which is a combination of exposure sensitivity and adaptive capacity, ultimately leads to how we track these adverse health outcomes. And so as we look at these adverse health outcomes, this is just sort of a typology of, different kinds of outcomes that we can routinely track using heat health surveillance systems. At the top of the pyramid are fatalities. As you go from the bottom, to the top, you see these outcomes that are increasing in levels of severity. Of course, the total number of deaths are much lower as we compare it to, let's say, the morbidity outcomes associated with hospital admissions, emergency department visits, and ambulance services. And what is really important to note as we think about these adverse outcomes, that it's just not heat stroke that we worry about, but we worry about a range of these other outcomes, like cardiorespiratory diseases, diabetes-related disorders, respiratory failure, acute renal failures, and then mental health illness as well. Because in our public health surveillance, we often underestimate and undercount, what the true burden of health outcomes or adverse health outcomes associated with heat is. This primarily happens because, when we look at these hospital records, these are the clinical classifications that are available, that allow us to track heat-related outcomes, ones that are related to, let's say, heat stroke or heat syncope or heat cramps or heat exhaustion and such. But a patient whose cardiovascular conditions or renal conditions or any other condition which may have been exacerbated because of exposure to heat, that particular patient, the contribution of heat to that particular heat health outcome is more often than not underreported or misreported in these heat records or health records that we have access to through the surveillance systems, which lead us to this tremendous underestimate of what the true burden is. And so if I could give you an example of what we the estimates that we currently have for India. So between 2000 and 2020, or I believe 2000 to 2019, these are different kinds of government sources that provided what the heat-related mortality estimates were for the country. And so if you look at the National Crime Records Bureau, you have about 20,000 heat strokes over this 19-20-year period. The National Disaster Management Authority have their own estimates, which is about 17,000. And then the India Meteorological Department have, in their sort of climate and health bulletins, they also provide, based on their estimates, the total, heat-related deaths were around, 10,000, 11,000. And so you could see that, even within these government statistics, there is almost a difference in, of a factor of 2. And the discrepancies basically arise because of differences in, methodologies and data sources and, reporting structures that these organizations have. And so it almost gives you, a very small estimate of what the true health burden from extreme heat might be. And this was a publication that came out in Down to Earth in 2025, which essentially did some district level modeling of heat wave related excess mortality in India, and the statistics that they produced were absolutely stunning. And so it says, one day of a heat wave across India could lead to an estimated 3,400 excess deaths nationally. One day of a heat wave. And if they look at events which may be lasting over a 5-day period, that estimate would be about 30,000 excess deaths. And so you can see what the discrepancies are between these health estimates. And it's really important that we think carefully about how could we potentially redesign and retool our public health surveillance systems, so that we can track these heat-related mortality and morbidity outcomes better. And what this research also found, or also suggested, that the heat-related estimates, the mortality estimates for the rural districts in India might be a severe undercount, because a lot of the analysis was actually using, data from urban areas in these estimates. So back in 2017, I did a study led by Dr. Gulrez Azhar, where we were looking at district level heat vulnerability. So it really, these kinds of heat health vulnerability assessments really, help us identify not only where these hotspots are, but what are sort of the contributing factors which make certain areas more vulnerable than others, from heat. And so what we did was we looked at these 17 different variables which were categorized by demographic ones. So we looked at elderly and children. We looked at gender differences. We looked at social and socioeconomic data. We looked at household amenities as a proxy for the level of resources that an individual or a family might have to prepare well against extreme heat. And then we looked at some of the these population level characteristics as well, both in terms of population health, as well as built environment features. And this is what we found out. So again, this is a district level map where the red districts show higher levels of vulnerability to heat as compared to the others. And if you sort of try and do a mental mapping of the heat related mortality map that I showed you before, you again see that it's that sort of belt across central India, where not only do we see high levels of heat vulnerability, but these epidemiologic analyses also show high levels of heat related mortality in those same areas as well. Going back to that exposure element that I was talking about in this sort of heat health causal pathway, the Indian Met Department, routinely produces these maps and information around, ambient temperature. This is again a map from 30th April, which shows in, this sort of persistent heat wave across, majority of India. It's really important to note that, some of these measures have different implications in terms of how we interpret what the risk is. So this map actually shows the one on the left is basically showing maximum temperature, but we know that temperature combined with humidity makes that the physiologic stress much worse. So for example, if you look at a 40 a day where the temperature is, let's say, 35 Celsius, which would roughly be about 94, 95 Fahrenheit. If that particular day is combined with 50% relative humidity, which is extremely common, across various parts of India, you would almost imagine, you would almost expect that the real feel for that 35 degrees Celsius day would be like 42 Celsius or about 108 degrees Fahrenheit. And so, the way we use these kinds of meteorological data as we think about, both heat epidemiology research as well as driving public health action, these exposure determinants are really critical, and our ability to track those with as much spatial and temporal resolution as possible is extremely important. What I really wanted to sort of show through this particular graph is when you see these maps and you say, oh, this particular area will have a temperature of 40 Celsius or 42 Celsius. It begs the question, how hot is too hot for health? And so, what this particular graphic is basically showing us, this is, an analysis that was published around 2020 and looks at, heat-related mortality data in Nagpur. And, what it's, plotting here is on the x-axis, you have temperature, and on the y-axis, on the, the top panel, it's basically a relative risk of, heat-related mortality. And, the days at the bottom are basically the number of days that Nagpur, in the year 2014, at the summer period of 2014, how many days were, at these sort of temperature bins. And, while it really shows that as the temperature increases, the relative risk of extreme heat increases as well, it's really important to note that the number of days where you have these extreme temperatures are small, compared to number of days where you would have moderately high temperatures, so temperature the range between 41, 42, 43, 44 roughly, as compared to the extremes around 47. And so, yes, the risk of extreme heat on these, extremely hot days are very high. But, through the epi analyses that we have done, we see that the majority of the heat-related adverse outcomes over the period of summer are happening in these moderately hot days and not only on these extremely hot days. And so it really have implications on, what would be the best way of issuing early warning systems around heat and health, keeping in mind that if you only issue alerts when it's extremely hot, you are going to miss a majority of the adverse outcomes that are happening on moderately hot days, versus if you're issuing these binary alerts of extreme of heat, over this entire temperature range, then you run into this issue of warning fatigue as well, where you're issuing too many heat alerts over the course of summer, and which might be confusing, for individuals, to take action. And so, as a community, I think we are increasingly moving away from this impact-related, these, hazard-related warning systems to impact-related warning systems. So, last year, this system was, implemented in the United States, in a collaboration between the U.S. Centers for Disease Control and the National Weather Service, where we are essentially producing these heat forecasts, which are calibrated with underlying health information. So the forecasts are available 7 days in advance. And not only is it telling you what the temperature level is, but it also gives you the associated risk of heat-related health impacts as well, where, these magenta categories or these red categories, denote very high levels of health risk, where, no matter who you are, one needs to take, some level of precaution, to be safe, on that sort of particular day. And so, you're sort of moving away from this, very binary system of denoting whether a particular day is hot or not, to these, impact-based forecasts as well. And then, these impact-based forecasts are also corroborated by what we can learn from, syndromic surveillance systems around heat. So the syndromic surveillance data, the advantage of using syndromic surveillance is that it really gives you that real-time, opportunity to track heat-related outcomes. And, this is again something that has been developed at the US CDC, where, we are using, heat-related emergency department information, which is available to us on a daily basis. And, we can corroborate, places which show high levels of heat. And so that's sort of that underlying map. And you can see that regions which have a high proportion of these red days or extreme heat days also show very high numbers of heat-related ED visits. And we can monitor this data every day so that, heat response strategies can be informed accordingly. And going back to the last part of my remarks, once we know what the risk is, what are the actions?
Could I interrupt for just a moment?
Yes.
I just wanted to let you know we have a cutoff time on the back end, so
sure.
We could just maybe try to wrap up in the next minute or two for Noah's talk.
Sure.
I appreciate it.
And so,
sorry to interrupt.
That's okay. And so these actions that we can take to reduce health risks from extreme heat, range from individual level actions to community to building scales to urban planning, to city and regional levels. You know, as we move from the individual to the city, there is increasing coordination challenges across multiple entities, because there are a lot of cross-sectoral coordination that needs to happen as some of these interventions are implemented. There are also larger investments that are required in most of these cases, with varying degrees of cost effectiveness information. And so, there's been some systematic reviews where we have looked at these heat health early warning systems, and there is increasing evidence that these city level or regional level heat health warning systems are very effective. These community-based heat adaptation interventions, which can range anywhere from cooling centers, to caring for elderly people, and making sure that those who are socially isolated, all of these potential interventions seem to be very adaptive, effective strategies. And then these individual level interventions, starting from use of air conditioning, access to fans. Fans are as effective as air conditioners can be in certain combinations of temperatures and humidity. Using water to douse, to wet your clothes, the specific clothing that one wears. All these strategies are found to be extremely effective. And all of these then combined to creating informing these heat action plans. And this heat action plan that was launched by Ahmedabad almost a decade back has almost been like a poster child, because of how coordinated it's been, how how successful it's been in engaging all these different sectors, so hospitals, labor, power supplies, schools, parks and zoos, in sort of creating this all of society approach as we try and mitigate the health risks from heat. And we also see that this particular action plan, when we looked at the data, we published this article around 2017 or 2018, where we were analyzing mortality before the implementation of the heat action plan in Ahmedabad and then afterwards. And we saw that the implementation led to a reduction of almost 1,000 heat-related mortality over this time period. There's a lot of good things happening in India as far as heat and health is concerned. The Global Heat Health Information Network, which is this joint office under the World Health Organization and the World Meteorological Organization, recently created the South Asia Heat and Health Hub, which is housed with the Council for Environmental Energy and Water, along with a few other collaborations and institutions. And I can get in a little bit more into this during the discussions if there is time. And so just for me to wrap up, while the warming of the subcontinent continues to threaten lives and livelihoods of millions, there are clear indications that the issue of heat is becoming a national priority. Through the establishment of these initiatives that I just mentioned. And at the same time, the commitment from public health institutes like PSPH to train a new generation of public health researchers and practitioners on various dimensions of climate change is really a huge step forward. And with the advances of our understanding of climate and health risks, the institutional support through funding and policy action, and a generation of a young workforce passionately addressing this issue, gives us a lot of hope that, communities across the country will need the critical support they need to thrive in a world that is getting hotter by the minute. So thank you so much for this opportunity, and I look forward to the discussions.
Thank you very much, Dr. Saha, for a really amazing presentation and very relevant, I think, not only in the United States, but definitely for the Indian scenario here. So let me now turn it over to Dr. Skowronek. Noah, I'm going to turn it over to you now, just in the interest of time. So please go ahead and share your presentation, and love to hear from you about your experience in building university research capacity.
Thank you for the introduction. Good morning and good evening from Atlanta. So let me just start by thanking you for the opportunity to be here today and to speak to you. And not only to speak, but to speak about something I don't often get a chance to talk about, which is how we've gone about building our research capacity in climate and health here at Emory. So as I prepared for this talk, I was able to just sit back and reflect on the past 8 years or so since we started doing this more intentionally, and during which time I think it has really paid off. So in that sense, I think this talk will be a little bit different than many of the other talks in this series, in that it's not as much about specific research findings, but rather about research capacity. But as I go, I will mention some of the research projects we have going on at Emory. So I'll talk probably about 20 minutes or so. I'll try to move it along so we have enough time for questions, but I've broken it up into two sections. So in the first half, I'll talk about our approach to building climate and health across the whole university, which is designed, partly to do more and better research, of course, and partly to enhance our competitiveness to acquire large-scale research funding. And then during the second half of the talk, I'll describe what we did once we received a large grant from the U.S. National Institutes of Health to create a center for the study of climate and health. So that's sort of the structure of the talk. Before I get into it, I do want to say that I'm not going to make any claims that either what we've done is the best way to do things or that it's right for your institution, whatever institution that may be, from the listeners. But I do think we've had some success, so I'm hoping there will be value for those of you who are working on similar things or thinking about it. And really, I've tried to make this as practical as possible. So first, just to go into how we went about building climate and health research capacity at Emory, I'm going to give you a few specific sort of tangible action items for how we did that. But before I do, I think it might be helpful if I explain in a little bit of detail what we actually wanted to achieve. So these goals are pretty simple, but I think essential. So the first thing is we just wanted to get more people involved in research on climate and health across Emory. I think that's pretty self-explanatory, but more people, of course, equals more capacity. So the second thing is we wanted to work on this issue using a variety of different types of approaches. And there are a few reasons for that. One is that there are just so many different types of problems associated with climate change and public health that many different approaches are needed just to deal with this diversity of challenges that are associated with climate change. But second, even if we leave that aside, having multiple disciplines and multiple approaches working on the same problem can, of course, allow for sort of more innovative and new solutions to address it. So in other words, we wanted people working separately on a variety of climate-related problems, but we also wanted people working together on the same problem in a sort of a multidisciplinary or transdisciplinary way. The third thing that we were trying to achieve, of course, is collaboration. We wanted people working together in teams, both within entities. So what I mean by that is within our School of Public Health, within our medical school, within our school of business, of law, and so on, but also across entities. So collaborating, across all the entire university. So with sort of these three basics, we figured Emory's researchers would do two things, right? They would do more high quality research, and at the same time, we would be ready to respond quickly to any opportunities that might come our way. And we really imagine these two things reinforcing each other, and I think they sort of self-evidently do. Good research helps be responsive to opportunities, and research funding opportunities leads to good research. So this was sort of the general framework, and with our goals in mind, those of us who were trying to build this capacity needed to know who at Emory was working on what when it came to climate and health and other things, and how they were doing it. And we also needed them to know each other so that we could have a plan for how to build teams that would work well together and were willing to work together. So that's really what we were setting out to do. So with that sort of basic framework, I will talk a little bit about what we actually did to try to achieve some of these goals. And again, they're pretty straightforward. I don't think they're necessarily rocket science, but they did seem to work, at least to some extent. And I'll talk about three specific items, sort of activities that we implemented, as well as a fourth one that wasn't implemented for that purpose, but had the side effect of helping build our research capacity. So the first thing we did, very straightforward, is we had to figure out who at Emory was already working on climate and health. And I want to stress that there are two categories of people here, okay? And I'm sure this is true at your institutions as well. There are the people who work on climate and health and know they're working on it. So these are the people who do work like I do. There are people who do work like Shabayu described earlier, and all the other people who are really deeply involved in climate and health research. I'm sure many of you listening would fall into this category since you're here with us listening. But then there's really an enormous amount of people at research institutions and universities who are actually working on climate and health, but they maybe don't quite think of it that way, or they don't really know that they're doing it. And they may be people like air pollution epidemiologists, they may be clinicians, they may be people who work on disaster response or food systems or infectious disease modeling or whatever it may be. And this is really a critical piece because this is a way you can immediately boost your research activity, your approaches, just the dynamism involved in your work. And that's because these folks have skills, they have expertise, and they're there and they're able to contribute immediately if you can get them involved. So in terms of how we found these people, it's more or less how you would expect. We asked around. We sent notes to deans and department chairs asking for their names. We also had some of our students conduct a literature review looking for climate relevant publications by Emory researchers. There was really nothing magical about it. It's just time and effort poking around. But ultimately, we came up with a pretty good list of folks working on climate and health or interested in working on climate and health. So the next thing we did is we set up a climate and health listserv that included these folks we've just identified. And we also invited anyone else who was interested in working on the topic. And we simultaneously set up a lecture series on climate and health. And we invited the people on the listserv. So it was a lecture series that was a little more informal than this lecture series. It was more inward facing, but really not so different in many ways. And it was just a way to keep people engaged, to get them to know each other, to interact on a regular basis. Through monthly seminars. When we could, we would socialize afterwards and so on. And then the third thing we did, which admittedly does take some modest financial investment, was we launched an internal pilot research program for climate and health research at Emory. So this was a program where Emory researchers could apply for funding to initiate a climate and health research project. But we prioritized a few types of projects. So we prioritized projects that were led by more junior faculty or faculty not already working on climate and health, or projects from established climate and health researchers, but they were applying to try out a completely new idea, and also for projects that were multidisciplinary in nature. And we had another feature of this pilot program, which was helpful, which is that the applicants could get more funding if they applied as a team. So really, we were trying to build in this incentive to collaborate from the very beginning. And then the last thing we did, which was not for this specific purpose, but it has had a positive effect, is we started a Masters of Public Health certificate in climate and health. So this is a certificate where our master's students in public health could specialize in climate and health. So it's really designed for educational purposes, but it ended up having this secondary consequence of really invigorating our climate and health research for a couple of reasons. One is that the certificate students are required to do their projects on something climate related, so naturally they're always looking for research opportunities, but also students have great ideas As you all know, I'm sure there are students listening now that have creative ideas that would never occur to me or other faculty, but that freshness has really been an asset. Okay, so that's sort of a quick summary of how we developed internal research capacity in climate and health at Emory, but really it's just a preamble to the second part of the talk, which is when I'm going to describe sort of how we took advantage of a major opportunity and how we approached it. So it won't surprise you to know that in the United States, the appetite from the federal government to fund climate and health research has ebbed and flowed over the years, but it did really pick up a few years ago, highlighted by a specific opportunity out of the National Institutes of Health to fund centers aimed at doing research as well as building research capacity in climate and health. So like dozens of institutions across the country, we applied for the opportunity, and we were fortunate to have been one of only 5 universities in the country to succeed in the first round, which is something I really attribute to what we've already talked about, that we were ready to go when that opportunity struck. We knew our strengths, we knew our personnel, we had relationships built, and people, probably most importantly, were excited to work together. There are now about 20 of these centers in the country, but we are still the only one in the Southeast in our region. So that one red cross there that you see is us at Emory in Atlanta. And what I want to do for the rest of the talk is tell you a little bit about this center, which we call CHART, which is it's an acronym for a long name of our center, the Climate and Health Actionable Research and Translation Center. So quickly, the center is set up as 4 semi-independent entities, which all interact to form the whole. And this broad structure is determined in large part by the National Institutes of Health. So all of the centers have some type of similar structure, but how they operate and what they do is pretty much left to us. So I want to talk about how we think about each entity and the purpose it serves in terms of research and research capacity. So comprising the 4 entities of our center, of the CHART Center, are the administrative core, which is sort of tasked with running the center, the budgets, the hiring, the strategy, the communications, and so on. I won't talk too much about that, but clearly it's fundamental to keep the center operating. And then we have the research core, which is the only part that's responsible for primary research. We have a community engagement core and a research capacity building core. So I'll talk about each of these, what they do, and how they interact. So the research core is, like I said, it's where we focus our research. And in the CHART Center, we focus on extreme heat in Atlanta. And within that topic, we have 3 projects. So we have a project that is specifically looking at heat epidemiology using hospital medical records from 5 Atlanta area hospitals. So we look at things like patient lab results, medication use, diagnoses, and so on. And that really allows us to look at a large population to understand who comes to the hospitals on hotter days and why those people are specifically at risk. The second project is a little different but related. It's a case control study where we recruit patients from emergency rooms who have heat illnesses at Atlanta area hospitals to learn about their exposures, their behaviors in the days leading up to it, their housing, their jobs, their life situations, and so on. So in other words, if they come into the hospital in the summer and they are diagnosed with heat illness, we try to enroll them in this study where we can try and understand their exposure pathways, their risk factors, and possible interventions. And then we have a third study where people in Atlanta can wear heat and humidity and air pollution monitors as they go about their lives. So it really allows us to characterize the type, the location, the magnitude, and duration of their heat and air pollution exposures. So these projects were really set up intentionally to try to triangulate how heat affects health in Atlanta and force people from different disciplines to collaborate. And we are still in the process of all three of these aims, but we have started to put out some papers on this. I think a lot more will come out in the next 18 months, but we have some new statistic-based studies on heat and health. We have a study on how certain medications seem to make people vulnerable to heat. We have a study on undiagnosed kidney disease and how it may be associated with some of the undiagnosed kidney diseases are also associated with heat. So that's the research core. Next, we have the community engagement core, which is a very interesting core whose role is really to make sure that chart research is relevant to the Atlanta community. It's culturally acceptable to study participants, and it's communicated in a way that is timely and appropriate for our stakeholders and for the public. So we have a committee composed of Atlanta-based partners from residence groups, nonprofits, other universities, and so on. And they do things like they help us develop our study materials, like the questionnaires, and materials for sharing back our results to the community. So this is just an example from our third project, where every participant who wears the heat and air pollution monitors actually receive an individualized packet of materials that shows them what the results were from their monitoring period, their heat exposure, their humidity exposure, and what that means. But the Community Engagement Corps has also done some of their own activities, like trying to map at a very fine scale all the different contributors to heat illness in Atlanta and where there might be intervention points. And the key reason I wanted to mention this is that we've set it up in this way. So not only is the research that's ongoing benefiting from this community input, but the community members themselves are providing ideas for next steps for future research, which was really important to us when we set this up. And the last thing is we have a research capacity building core. And this core does things like organizes webinars on different aspects of heat and its influence on health. These are public. We've had seminars on heat effects on babies and pregnant mothers. We've had webinars on heat health associations in emergency departments and so on. But in addition, this core has continued our work funding these pilot projects, trying to get more Emory and partner researchers working on climate and health. So through CHART, our researchers can get funding either to initiate their own new projects, or if they have an idea related to CHART research, they can apply for funds to slot into the ongoing CHART research and build on that infrastructure. So this example here is a study from one of our newer faculty members who works on sleep, and she joined this third project. So some of those participants were not only being monitored for heat and air pollution, but they were being monitored for sleep quality and quantity. And she could then analyze how heat might be influencing their sleep, both objectively and subjectively. So in the name of time, I think I'll stop there. That's sort of a summary of our CHART Center and what we're doing and how it functions. I know I've thrown a lot of things at you already. I don't want to take up more time, but hopefully I've given you something to think about as you're trying to build, if you're trying to build research capacity in climate and health, which I encourage everybody to do. And also, of course, you can join the CHART listserv, check out our website. We are going at least for another 6 to 8 months, but we think we'll be functioning longer than that, depending on how different opportunities play out in the coming months. But we would love to have you involved and maybe build some collaborations across the various dimensions I've talked about. So I'll stop. I thank again the organizers. I've known about this lecture series for a while now through Dr. Falk. It's really a great honor to be able to be with you this morning. So thank you very much.
Thank you very much, Noah and Shivayu, for a couple of really wonderful talks. We are quite tight on time. we have a bunch of questions which we will unfortunately not have time to get to, but I would like to ask each of you, maybe just respond very briefly to one question for each of you. And since we have you, Noah, right now, could you just elaborate a bit on what some of the significant challenges you ran into at Emory in setting up the Chart Center? How did you deal with those? I mean, I have some idea in my head what I think some of the challenges might be, but what were those and how did you deal with those? If you don't mind.
Yeah, sure.
Yeah.
Thanks for the question. I mean, I think, fortunately, in some sense, because this part of the idea behind these centers was to build capacity, we were expected to take some time to set things up. But that has also been a challenge as well. So anytime you're setting up a new center or sort of research entity like this, it takes longer than you think to get it going. And that's because any type of research takes time, but also when you start involving community members and you start involving multiple departments and you start involving people from different disciplines, that timing can be tricky and building those relationships can be tricky. I think we had a head start, which was great, but we did run into a few problems, and I'll describe those a little bit. One is that it's taken us a couple years to really get going. So I think that's normal, but we feel like we're ready to go now, and our research results are about to be available now, but we don't know how much longer this is going to go on. And that can be a challenge as well, because we really want to use what we've built for communicating the results, for making it policy relevant, for being able to engage people outside of Emory. So I think just the alignment between the research findings and the length of the project is a little bit tricky because, as we all know, academic research always takes a little longer than we expect. But we've also run into some specific problems, which I think have just been interesting. For example, in our case control study, we've had a lot of trouble recruiting people in the emergency rooms. So I'm not a clinician, but maybe this should have been obvious, but it's really hard to identify people in the emergency room and have them be interested in participating. They're not feeling well. They've just been through something very difficult and that sort of thing. But also what we found, and Shabayu alluded to this a little bit, is that many of our patients who have heat-related illnesses have a lot going on in their lives that's challenging, including many of them were homeless, for example. So just being able to identify folks that are really the most vulnerable folks and try to understand their experiences has been harder than we had imagined. And that's unfortunate because they're the ones that we really want to make sure we're able to protect as we move forward with our work.
Thank you very much. We do have one question also for you, Shabayu. Could you comment briefly on what some of the most important collaborations you've utilized to drive this heat action agenda forward in tracking California? And also, I think we're particularly interested on how you've engaged with communities in sort of meaningful ways. I know Dr. Noah has touched on that briefly as well, but would you mind elaborating on that aspect a little bit, collaboration and also engaging with communities for the work that you're doing in California?
I'll start, thank you, Dr. Kapil. I'll start with the latter question. The engagement with the communities have taken a lot of time. But we have, over the last 5 years or so, been very intentional about working in rural and tribal communities, acknowledging that they are the risk of heat, the vulnerability of heat is highest in those communities. And so, because we have worked with, these environmental justice and community-based organizations for a very long time, there was this sort of, trusted relationship that we were able to cultivate over time, which is absolutely instrumental. And, as we are, now going in and, doing these implementations of cooling centers, resilience hubs, distributing heat resilience kits, and not just distributing them, but, tracking these individuals and communities over time, to assess how effective, these interventions are. And just in terms of the coordination, of course, funding for these opportunities is really critical and scarce in the United States, as it is, across the world. But, particularly in the Indian context, I alluded to the South Asia hub that's been established at CEEW. There's been sort of, a couple of other initiatives that would be really, interesting to follow and track and build upon. There is an organization called Indian Institute of Tropical Meteorology in Pune. And, they just received, funding from the Rockefeller Foundation to become the climate and health hub or desk, for South Asia. And then there has been, support from Rockefeller and Wellcome Foundation, I believe, to create a South Asia Scientific Research Consortium in the Indian Institute of Science Education and Research in Pune as well. And so, all of these are funded to promote this community-based participatory research model as much as possible in this sort of heat and health landscape. And I think these collaborations would be extremely critical in sort of driving this action agenda forward in the context of India.
That's great. Thank you so much to both of you, Dr. Saha and Dr. Skowronek. Unfortunately, we are up against the end of our session today. And we have at least 9 or 10 other questions, so we could really sit and pick your brains for the next half hour. But we may take that offline. We may still come back to you with some of those questions and discussions. And I think, as Noah mentioned, I do think there are lots and lots of opportunities on the issues we've discussed today for potential areas of collaboration as well. So we will definitely take you up on your offers and maybe have some further offline discussions with both of you. Thank you so much for getting up so early and joining us and presenting to this audience. I'm sure people have greatly appreciated your remarks. I also, just as a way of wrapping up here today, I want to thank again our guests of honor, Professor Rajani Prasanna, Dr. Henry Falk, and the entire Prasanna family, really, not only for joining us today, but also for your vision and your leadership on climate and health issues, and also in public health in general. This is really transformative here in the Indian landscape. And thanks also to Dr. Cherian, our director, our PSPH advisory board member, Henry Falk. And I would be remiss if I didn't thank our team here at PSPH. So for Alyssa, Dr. Rahul, and Manu and all the others who helped us pull this program together. Thank you all very, very much. And we will be signing off now for today. My apologies. We do have a couple of other closing remarks. We do also intend to publish the second edition. We have published the first edition already. So the second edition will be published hopefully in the next few months. We will be pulling together all of these talks, the abstracts, the summaries of these talks. So please look for that later this year. Without further ado, let me turn it back over to Mr. D.A. Prasanna, who will close us out for the evening today. Thank you, sir.
I just want to share a thought with you, Dr. Kapil, and the speakers and Dr. Cherian. What I have seen is that in this heat issue, one of the most vulnerable people are those who are working outdoors. And I will take example of 2 cohorts. One is, for example, the people in India, there's a large amount of construction going on. There are more than 1,000 kilometers of metro network being built by thousands of people.
Yes.
See, similarly, the railway networks are being doubled, tripled, modernized. A lot of people are working on conventional railways, and so are the highways. And they're all working in the heat, except the metro. The metro, as a rule, is working only in the night. They don't work during the day at all. So the average temperatures in the night, even during very hot days, is significantly lower, and the risk they face is lower. So what I am suggesting is that there could be some advocacy on during the heat months, with working hours for construction workers in these sectors could be drawing the example of metro. Try to do it in the night. Thereby, you can save a lot of lives. The second, since the time is short, I will quickly tell about the second one, is that India has 4 or 5 million gig workers for delivering food, this, that, and the other. And they're all going in the sun. And they're all under corporate management. So I think there has to be advocacy on these corporates that they have to devise methods of heat sensitivity, even suspending, the service in the peak heat of say 2 p.m. to 5 p.m. Don't offer the service at all. People will understand. The 3 months, because lunch is eaten before 2 o'clock. 2 to 5, give them complete rest. Something like this, the corporates have a responsibility on millions of gig workers who are exposed to heat, and both these segments are from the poor, vulnerable communities. And this is the thought which came to me when we were talking about the heat issue. And I would urge both at India level and outside level, some attention could be given to how working hours impact heat challenges in working, and whether change of working hours can mitigate. I stop here.
I don't know, Dr. Noah or Dr. Subhash, do either of you have any thoughts on that? Mr. Prasanna has raised this issue of these vulnerable groups that are sort of occupationally vulnerable, if you will, and potentially sort of administrative interventions in terms of hours, time of work. I suspect there's a lot more of that here in India than in the US, but nevertheless, I'm sure you've dealt with this in the US as well.
Yeah, I think that's exactly right. The occupationally exposed are very vulnerable. We've seen it in some of the numbers of who shows up at hospitals for heat illnesses are always a little higher in working age people than you would expect. And I think part of that is because of occupational exposures. And the interventions needed are going to be diverse. So we have a project in our School of Nursing who works with farmers in Florida, and they're testing out anything from hydration interventions to cooling clothes that keep their core temperatures cooler and that sort of thing. But I think when they work is also going to be a component of this. It's really going to need to be a multi-dimensional intervention space to protect those folks. There's no question about it.
Thoughts from you?
Just to add to that, in terms of sort of federal or even state level policy, around heat prevention, I think the occupational heat safety ones are probably the ones that have been most important and most talked about in the last 3-4 years in the country. So there have been attempts to impose federal standards, which have not been very successful, but there are certain states like California where, these standards are established. They are monitored with a lot more regularity and fidelity. And these modifications of work hours, for example, is something that's not just happening in the occupational health setting. Even schools are doing that. There are the many schools which have change play schedules or outdoor activity schedules for kids and young adults. And so these kinds of modifications in daily routines are something that probably would become even more important and common as heat becomes worse and worse. So I think both points that you raised are absolutely vital.
Thank you both. Professor Rajani, Surbi, any closing remarks before we close out? Dr. Cherian, anything from you? Henry, any thoughts you want to share with the group? Yeah.
Yes, I think this has been a very valuable session, and I don't think Noah included nor Shubayu in their talks about global collaboration, sort of extending out what you've been thinking about to broader networks. But I think, there's a lot to be done in India, and collaboration could be very valuable. In addition to encouraging Noah, as he said, to speak, I've encouraged him to think about global collaborations as well. So for both of our speakers, I think that they don't have to respond now, but I think that's an interesting aspect of future work.
Yeah, well, Professor Rajani and I were actually discussing that just briefly before the session began. So I do think that there are some potential areas that are sort of ripe for exploring further with both of our speakers today. So, okay. Anything else, Dr. Aaron? No, that's great. Thank you all very much. And it was a great session. And maybe we can have a round of virtual applause for our two speakers. Thank you. All have a wonderful morning and evening. Thank you all for attending.
Thank you.
All right.